give it another 30 seconds for people to join, and then we'll start off. We'll just give it another 30 seconds for people to join, and then we'll start off. Right, okay. A very good evening, ladies and gents, and welcome to the third episode of the British Hip Society Midweek Special. I'm Vikas, Khanduja, consultant orthopaedic surgeon in Cambridge and chair of the education committee in BHS, and it is indeed a pleasure to welcome all of you to this webinar. Now, our aim with this series is to bring together clinical cases and discuss nuances of decision-making and management from key opinion leaders in the field of hip surgery in UK, so that we can continue to fulfill the Society's manifesto of sharing knowledge and improving patient care. We've had two excellent sessions on primary total hip arthroplasty already, and the session today will be focused on early complications following primary THA. Moderating this session today would be Mr. Anil Gambhir, our treasurer and consultant orthopedic surgeon from Wrightington, with a stellar faculty including David Beverland, Philip Mitchell, and Simon Buckley, and I'll let Anil introduce them in a moment. We're also delighted to be collaborating with OrthoTV Global for this series and welcome all the viewers from the Asia Pacific region who are able to watch this live streaming at no cost via OrthoTV. We strive to make every session as interactive as possible, and therefore please do post in your comments and questions in the Q&A box. Our panelists will address these questions as we go along and choose some of them to discuss live at the end of the webinar. For those of you who are enjoying the sun outside and are not able to join us live, we do have the option of on-demand viewing via our educational platform, Panopto. So please do log in via the British Hip Society website and you can watch it later. Once again, a very warm welcome to all of you and hope you enjoy the series. Anil, over to you.
Thank you, Vikas. A great privilege and honour to be with you tonight. Can you all see my screen? Fantastic. So as Vikas has already explained to you, tonight's webinar is about the early complications following primary total hip replacement. And rather than simply having a didactic series of presentations, we thought it would be much better and much more interactive to talk you through almost like an MDT style discussion around cases. As Vikas has already alluded to, I'm joined by some real heavyweights from the world of primary arthroplasty in the UK, all of whom need no introduction. David Beverland is a previous high-volume hip surgeon based in Belfast. He tells me he has a long and continuing research interest into trying to do it better. Simon Buckley works in Sheffield as part of the lower limb arthroplasty unit, has a wide experience of both primary and revision arthroplasty, and is currently the editorial secretary at the BHS. Phil Mitchell works at St George's in Swelliok, was appointed in 2002, is the network lead for Southwest London for hips and knees, and is currently on the Professional Affairs Committee of the British Hip Society. Complications following primary total hip replacement are many, and we've chosen three issues, and hopefully we can draw out some themes and some learning points. We've chosen to talk about early dislocation and how to prevent it, leg length discrepancy, and again, how to prevent it, and intraoperative periprosthetic fractures. We've purposely avoided talking about recurrent dislocation and infection, both early and late, as these are the subject of other webinars to follow in this series. So we're going to kick off with early dislocation. So if I hand over for the first case to my colleague, Simon Buckley. So Simon, if I can get you to talk us through the history here, please.
Yeah, good evening, everyone. So this is a patient who came to our unit actually as an 88-year-old gentleman, examined a little bit obese, as you can see from the X-ray image, and a somewhat deformed spine. surgeon who saw him, examined him, felt his spine was quite stiff, but his main problem was his arthritic hip and his pain from his hip radiating down the thigh into the groin. Planned the surgery through a posterior approach, and was very keen to be concerned about the risk of dislocation. So certainly made sure there was enough antiversion in their opinion on the cup, and these are the immediate post-operative films, which in all honesty don't look particularly of any concern. Unfortunately, the patient managed to dislocate 3 times in the first 4 weeks, each time actually dislocating anteriorly, and having to be reduced in theatre twice and once in A&E with propofol, the third time probably becoming easier and easier to do it. So the issue there is what to do. Patient was, we would talk back to theatre eventually. After third dislocation, you can't keep these people, an 88-year-old gentleman, keep coming back in, dislocating. So took him back to theatre, examined him, and actually, although radiologically on the x-rays it looks reasonably good, the cup was more than enough antiverted. So we revised the cup to a slightly more neutral position and a longer head, which I know with a skirted longer head is an issue, but felt by the surgeon at the time that rather than revise all the stem, that was the simple and easy. It made the hip stable, and a year and a half later, the gentleman is still stable, never had a problem with the hip since. So probably the simple, easy way out. The worrying fact, I think the surgeon had thought about the risk of the stiff spine, made a plan ahead of it, and then unfortunately probably we'd slightly overcooked the antiversion, and that was the issue with this case.
So Simon, let me ask you, with the retrospectoscope, I appreciate you weren't the index surgeon here, but with the retrospectoscope, now that we know a lot more about spinopelvic relationships, would you have done anything different had you been the index surgeon?
No, I would have thought about it. I'd have had it in my mind. I'd have been worried about the risk of dislocation. You're always going to try to get the combined version right. And I've always, through my time, followed the theory of get the socket back where it wants to be, where it has been. I haven't chased the extra antiversion, but it's very difficult. I don't think, on table it was felt to be stable. There was no concern or issue. I think it's such a difficult issue. And how mobile are the spines? We don't routinely still at this point do the x-rays as were discussed at the recent BHS meeting with standing and sitting films. But I think increasingly with patients with stiff spines, people are considering doing that. We don't have access to an EOS system, which was discussed as well at the BHS, but it's just something to have in your mind. But I don't get over concerned about it. At this stage, I don't know what the others would feel, but
Simon, can I ask you? So, in this scenario, you've not revised the stem or the cup; you've just lengthened the head, haven't you?
No, we revised the cup because the cup was significantly antiverted, so he was coming out the front easily. So we've brought the cup back round slightly, not a long way, just enough.
So you've reduced the combined antiversion.
Yeah.
That's fine. Phil, can I bring you in? Would you? We know a lot more now about spinopelvic relationships. What's your workup for these sort of patients?
Similar to Simon, I've been really grappling with trying to understand the principles, quite frankly. But I think the big thing that has changed in my clinical examination is actually looking at the lumbar spine. I mean, until about 2 years ago, probably the lumbar spine was never really even clinically examined, not even seen, as the gown would sort of end at the top of the underpants or the underwear, and I wouldn't even look at the spine. But I think where I am at the annual meeting this year was great, wasn't it? And we learnt a massive amount. And Steve Jones at the last meeting really strove hard to help us understand this. I think where I am in this now is, and this case highlights it brilliantly, is the stiff flat back. Because we are all, those of us who routinely perform posterior approach, we are concerned about combined antiversion, aren't we? And combined antiversion in this case was fine in terms of not encouraging posterior instability. But that patient with a stiff flat back, which clearly this patient is, they are more prone to anterior instability. So I'm examining the spine. I'm starting to think about the radiological investigations. I'm not sure. I mean, a robot's going to help you in terms of where you position the implants, but you've still got to decide which patient needs some potential alteration in combined version based on their spinal pathology. And the one group of patients that I think I've learned a lot about, and we'll see a little bit from the next case, but the stiff flat back, slightly reducing my combined anteversion, because I am very concerned about anterior instability.
Okay, so we've had a question from Tim Petheram, Simon. Was the first cup a low-profile contemporary cup with a posterior elevated lip?
Yeah, the extra contemporary cup, yeah.
That, of course, that's a really good question, isn't it? Because if you're using lip liners and you're doing a posterior approach and you're so worried about posterior instability, you're putting the lip at the back. If you've got someone with a stiff flat back deformity, then you're even more potentially in trouble with respect to anterior instability, aren't you?
Okay, so let me move on to the second case, and I'll bring you in, David, after the second case, if that's all right. So this is your case, Phil. Can I get you to present this patient?
Yes, of course. This lady, 63 years of age, quite an active lady actually, but that X-ray doesn't quite show the whole story. She presented with 2 arthritic hips, and when before I did the first one, she presented me with the long scar on her back and a letter from her spinal surgeon at Stanmore saying that she'd had this very long spino-pelvic fusion, and perhaps I ought to think a little bit about where I put the implants. And this was before the conversation in our group had really moved on to spinopelvic deformity. It was very, very, very early stages anyway. So I did both her hips and perhaps anteverted them slightly more than usual, as I was directed by the spine surgeon from Stanmore. But she was very happy with them until, unbeknownst to me, about 3 years later, she's admitted to the Wellington for a 2-level cervical spine fusion. And on the day that she was leaving hospital, her suitcase was on the floor, and she was packing the suitcase before she was being picked up by her husband, and she dislocated her hip posteriorly. And I was obviously very upset about that, very disappointed. I thought long and hard about it, and of course I had actually consciously chased the combined anteversion, this lady. I couldn't quite work out how it happened, and then it sort of dawned on me really that the only way this lady can look down and reach the floor is through flexion at the hips now, because her neck is stiff and her lumbar sacral segment is also completely stiff. So a bit like Simon's case, really, I allowed it to happen 3 times because it just was so hopeful that it might settle down. Of course, it didn't. And we decided that surgery was the way forward. So when I explored this lady, I mean, I knew I'd put the cup in, so I knew where it was. I just could not bring myself to increase the version anymore on the cup. It was in the best position I could really put it. I just couldn't bring myself to change it anymore. But I felt like I had to do something. So of course we went for dual mobility, and we went for a slightly increased offset and length, redid the posterior pair, and so far so good. So it was an early complication, but not necessarily of the hip, but of multiple spine stiffening and procedures.
Okay. So David, perhaps I could bring you in on this. I mean, you've looked at dislocation in thousands and thousands of patients. I think you told me you've done over 10,000 hips now. And obviously you've published widely on socket position. How do you handle these patients with stiff spines and spinopelvic issues?
Yes, well, I'm not doing so many today, but certainly, I mean, I think increasingly these patients should have a dual mobility cup. I think trying to pick a particular version for a patient is difficult. You know, as Phil says, you can use a robot, but the evidence is even with robots, it's not that accurate. And certainly, if these patients were in France, they would all have durability first up. And at the moment, it's interesting. I was on a call today on durability. At the moment, there are 10% of hip surgeons in France who use durability on everybody, which I think is crazy.
Wow.
But over 2/3 of them would use it on patients over 70. And they're very good. And certainly on a younger patient under 70 with high risk, they go straight to durability. So I think increasingly that's going to become the solution, because there's no published evidence yet that so we all accept that spinal pelvic disease is a cause of dislocation, but what nobody's proven yet is that choosing a particular version for the cup decreases revision rate for instability. But we do know that durability has a very low risk of instability. So at the moment, I think if you're in doubt, just put the cup where you normally put it and use durability.
Okay. I'm going to move on, David, in the interest of time, to my case. So this lady's 65, OA of the right hip. She undergoes a right hybrid total hip replacement. She has quite a small socket. It's only a 48. The surgeon used an offset and a lip liner, and I want to try and bring out some conversation about lip liners, if that's all right. Initially did well post-operatively. At about 4 months, she tells me she was walking in some mud and she felt her hip almost shook and pull out of its socket, and since then had difficulty weight bearing. Attended A&E, and as you can see, her socket's not, her head's not in its socket. At EUA, the surgeon in question wasn't sure whether the hip was actually in joint or out of joint. It was referred along, and that's an x-ray that I saw at 5 months, and I chose to manage her conservatively. But it happened again, and quite clearly there's an issue. But at this point, she starts to develop clicking and squeaking, David. So this is a ceramic on polyethylene bearing. And I think you, in our sort of pre-discussions about this, you said that's pathognomonic of a liner dissociation.
Yes, correct. So if a patient with a metal or ceramic on poly articulation starts to habitually squeak, in other words, they squeak every time they move their hip, that is pathognomonic of a liner dissociation. And in fact, in terms of risk, a lip liner actually protects against it. But I think probably it happened so early after surgery that the liner probably wasn't engaged properly.
Okay.
In this case.
And that was exactly what I found when I went on to revise her. So let's talk a bit about lip liners. So there was a message certainly came out of the Newport meeting at the BHS last year that lip liners, there's a lot of strong evidence in the registries about lip liners. So David, I understand that you use lip liners in everybody. Is that right? Yeah,
I do now. I was very strongly opposed to lip liners because of risks of impingement. But you know, the published evidence from the New Zealand registry, the Australian registry, and a new study about to be published from the NJR shows that if you use a posterior approach, then a lip liner does reduce your revision rate for instability. Okay. And that's 3 registries all saying the same thing. I know there are arguments about impingement, and obviously, as we heard earlier, the first patient came out the front. Obviously, a posterior lip is not going to reduce that risk. And as Phil says, it will increase it. So it's a bit like the argument, if you wear a seatbelt in a car, occasionally it might be bad for you. But on average, a lip liner, if you're using a posterior approach, reduces revision for instability.
So David, if you are doing a right hip replacement, where do you put the lip? On the face, on the clock face, where would you put it?
Right. Well, I put it directly posteriorly. So would that be 9 p.m.?
Okay.
Is that correct?
Yeah, but you mentioned to me the other day that it depended upon the inclination of the cup.
Yes, in theory, if your cup is a bit open, you would put it posterior superiorly. If it's a bit closed, you put it posterior inferiorly. So hopefully now our cups, my cups are more in the middle. So I tend to put it directly posteriorly or a little bit posterior superior.
So your default's 9 o'clock. Phil, can I bring you in on that point? So I think you do hybrid hips, don't you?
Yeah.
Do you use lip liners or not?
No. Of course, I looked at those presentations very carefully, and I've read the papers and looked at the registry evidence. And I think this is personal opinion. What we're seeing there is, the big data bringing out statistical significance across a massive population of patients and surgeons. So, I mean, in my own practice of performing posterior approach for nearly 19 years now as a consultant, my posterior dislocation rate and revision rate are touchwood extraordinarily low. And I think that's because, I listened to David and others right at the outset of my career. In my fellowship, I was taught very assiduously about combined anteversion. And I'm really good at exposing the acetabulum before I put the socket in. Now, my observation of revising a lot of hips is that the cup anteversion is not usually as much as when I do a primary hip. And I think, therefore, that the combined version that I've been getting over the years has meant I haven't needed a lip liner. That's what I'm trying to say. I think in a big population, this comes out as significant. And I suspect that's because people are not exposing the acetabulum as carefully and as rigorously as perhaps some do. I think I've observed that cup version is not as much as perhaps it should be in many, many cases. And I think that's because people are not routinely getting the femur out of the way so they can put the reamer handle and the cup insertion handle in the place that they want to effortlessly with the femur out of the way. And if your cup is going in a little bit less anteverted than you want, then of course a lip liner is the only way forward. And that is what I think we're seeing in the literature.
Okay, well, that's fine. So I'm going to move on to David. So David, can I get you to take me through these slides?
Yeah, so very brief. There's a paper that we published last year, just a long series of mine, and I tried to be conservative with my management. So, for example, that first case we saw of the elderly man who came out 3 times in the first 4 weeks, he was 88. So if he was frail, so anybody in my practice who came out anteriorly on 2 occasions within the first few weeks, they've used a half spica. So that's on the side is affected, a spica down to the knee, up to the chest, but the other limb free. And then again, if they come out twice very early posteriorly, then a long legs cylinder cast. And certainly that's very effective, because if the patients stay in for 6 weeks, they tend to become stable. Overall, then we'd 92 hips revised. In the early part of my experience, my dislocation rate was over 3%, going back to the late 90s, which was terrible, obviously. But as you see there, of the 92 hips that were revised, only 5 had a full revision. So the other 87 had intervention on the acetabular side only, like a PLAD, a posterior lip augmentation device, or a constrained liner. And all of those, and we've no patients in that series of over 8,500 who have a Girdlestone, and they're all stable. Is there another slide for me there?
Yeah.
And then in terms of so the key thing for me that reduced my instability rate, I was using TAL, which I started to do in the late 90s. And as Phil says, the key thing in acetabulum is to expose it properly, find TAL, and then make the face of your cup parallel to TAL. So in terms of version, I think the key to version is the transverse ligament. And irrespective of where the pelvis is, obviously, the transverse ligament remains constant. But the inclination is different, and the sagittal plane is the key to inclination. And again, we published on that there, but it's essentially, if the pelvic sagittal plane isn't parallel to the floor, you can get very high post-op angles on your X-ray, just because of the distortion. So if you aim for 35 during surgery and you use an inclinometer and you put it in at 35 degrees exactly, it will not be your requested or your desired 40 on the X-ray if the sagittal plane is not parallel to the floor. So how you set the patient up is key to inclination, whereas tau is the key to version. And the other thing is then the true floor. And we were all taught to ream to the true floor, and everybody blamed Charnley for that. And if you go on to the next slide, then just so you can see here that Charnley said on page 341 of his book, which I'm sure most of you have, in the average patient, the acetabulum isn't deep more than 5 mils because there isn't sufficient bone to permit this. But what people don't focus on is the second paragraph. And where deliberate conservation of deepening is important is in large men with very large acetabulums. In these patients, it's possible to deepen by 10 mils and sometimes as much as 15 millimeters. But even here in recent years, surgical facts have been leading us away from gross deepening. So that was said by Charnley in his original book. So I think it's important that we don't routinely ream to true floor, especially in large males with deep. If you have 15 mils of floor depth, you then lose 15 mils of offset. And that gets into awful problems when you try and compensate for that on the femoral side.
Phil, you wanted to make a point.
Thank you, Anil. David, just 2 quick questions, if I may. Do you think it's wrong of me in these patients with stiff flat backs to not go necessarily parallel to tau, but just perhaps slightly behind that with my version, which is what I've been doing? And second question, what about hypermobile female? Because they're the other ones I think are prone to anterior dislocation.
I do think at the moment that if you're a high risk patient, I think the best thing is a dual mobility cup. Problem? If they have a good lumbar spine movement.
Yeah.
So I would always go on tau, but unlike you, then I think there is I think you can make a case for using a lip liner.
Yeah, brilliant. In the interest of time, I'm going to move us on to leg length discrepancy. So Simon, can I get you to present this case on a leg length problem?
Yeah, thanks. So this is a 56-year-old chap, pain in the right hip, otherwise fit and well, active, still working hard. When you look at his X-ray, he's got a fairly varus neck, not terribly varus, but you'd say the head is not significantly higher than a greater cancer, which is something to be aware of. Listed for hip surgery, has an uncemented total hip device, and there were noted to be a few struggles getting the rasp in. Tight cortices, really. He's got a Doré type femur, and this is immediate post-op film. And the patient the next day said it felt wrong. He knew something was wrong, and it significantly was on the X-ray. He wasn't happy. We took him back, corrected his leg length with a cemented hip, and the leg length is right. So he was happy, and he's not been back since. So the message really, simple message really is a varus neck angle, but uncemented stem in a tight canal, which is an issue. And because particularly in blokes, I think they tend to have a larger offset. The uncemented stems go up in offset size as you go up with size, and you need to get to a certain point to get the right offset. If you can't get the right size stem in, you have an issue, and sometimes you have to use length for stability. And I know I've seen that recorded in a number of notes when they come across to us for review. Case really that has a bit changed my practice, because I've stopped using uncemented stems. I cement the stem now in pretty much everybody, unless there's some very weird anatomy. I'm using cemented stems for everybody now. Now, not just one case changing it. There's lots of other evidence as well, but it's something that puts it into it, because you can get a cemented stem into pretty much every canal, however tight they are.
So I'm going to come on to so Phil's got a similar case, but nowhere near as well. Phil, let me you talk us through this one.
this is a case that has come to me for a surgical opinion. I haven't been involved in the litigation which I'm about to present, but so this is a lady who had her right hip replaced not that long ago. And if you go straight to the post-op X-ray, Anil, so this is successful litigation for leg length discrepancy. And it just goes to show, much like Simon's case, that the varus femoral neck is the risk factor. I'm not entirely certain that the canal is that tight in this case. I just think that there was perhaps failure to template, failure to plan, failure to appreciate where the centre of rotation of the femoral head was in the native hip before the hip was replaced. And this, again, is very poorly tolerated, to the point that she was just so disappointed and felt so disabled that it found her way all the way to the solicitors, and it ended up in successful litigation, nothing to do with me whatsoever. So, again, varus femoral neck uncemented implant is the commoner theme here, but I don't think in this case it was particularly the tight canal.
And she's not even that long, is she?
No, it just goes to show in some patients, they just cannot tolerate it. And I think younger age, a fairly mobile hip, relatively athletic, quite high demand, instantly feels there's something wrong, perhaps told by one of the physios in the early post-op period that it was a bit long, very difficult to shake that off. Everything reinforces the fact that the leg is too long, and it becomes a really big problem for everybody, including me now.
Okay. Let's move on to David's slides, because you're going to talk about neck cuts, aren't you, David? So should we go through these?
Yeah, so I have to make a confession as being a cement-less surgeon. So essentially, a long limb is caused by making your neck cut too high. It's as simple as that. Because if you make your neck cut too high, you tend to put your stem in the same place. So this example here, then you can see, if you go on to the next slide there, just for me. Yeah, it's been templated for a size 10, but the canal hasn't been measured, and the canal diameter, as you can see there, is 8 mils. And you can see then that the collar of the stem is just above the lesser trochanter, and even then it's a little bit proud because head center isn't quite right. So really it should have been a short neck variety to begin with. You go on to the next one if you could then for me. Post-op, you can see the telltale sign immediately that the collar hasn't gone down onto the calcar, and the stem is jammed in the canal. And even that last one that Phil showed, the canal was too tight, Phil. I mean, I'm sure it was a tight canal as well. So it's a not uncommon problem, and it's more common in females because females tend to have smaller canals. So it's not always a door A; it's often the female door B. If you go on to the next slide for me, then you can see that remember that the planned neck resection was even lower. So this again is a common problem, and then the key thing is here to measure canal diameter on the pre-op X-ray. And in my practice, if the canal is 10 or less, I always ream the canal. And it takes an extra 3 seconds. And it avoids all these problems of leaving the leg long. So commentary then, undersized in the metaphysis, too big in the diaphysis. So this is a classical metaphyseal-diaphyseal mismatch, leading to a diaphyseal hang up on a proud stem, which isn't seated on the calcar. In addition, the neck cut's too high, and this patient complained of a long leg. Wasn't revised, but definitely not a happy patient. The next slide then. So this is a paper we published just last year. And essentially, this is just showing a picture of a large male and a small female. But remember, during surgery, we don't see how big the femur is. All we see is that little area around the trochanteric fossa. And what surgeons tend to do is to cut every femur in the same place. And you can appreciate then when you do that. Move on to the next slide there. You can see then that when you put a stem on top of that neck cut, you're going to be much nearer to head center on the small side. So that's what commonly happens. And again, you can move on from me. So out of habits, so out of habit, surgeons tend to cut the neck in the same location, and then we use a femoral component with the same size of head and neck geometry. And therefore, in the small female patient in particular, you tend to lead them with a long leg because your neck cut is too high. The next slide then just. So this again, we published this just last year. So the conclusion was that females have a smaller femur, leading to a bias towards a more conservative or higher neck cut compared with males. And this didn't lead to them feeling that a long leg very often, but it affected their improvement in Oxford hip score. So their overall Oxford score and their pain scores were inferior at 1 year, even though they didn't actually complain of a long limb. So an important lesson, I think.
Okay. So in the interest of time, I'm just going to ask Simon. Simon, tell me, how do you make sure that your patient's got equal legs at the end of the operation? Take me through your...
Very clinical, I have to say. When I do it, it's not, I don't have a robot. I don't use fancy measuring devices. Very clear clinical examination, both in the outpatient clinic and then again on the day of surgery in the anaesthetic room. Patient supine, get a really good idea of the leg length. Plan the surgery before, have a look at the x-rays, get a template on, see if there's a significant difference, see where your stem is going to sit, particularly with those varus or valgus necks, so that you know where the head center is going to be relative to the greater trochanter. And then once the patient's positioned, check again, feel tension, feel the kick test, feel the tension in the quads and the thigh. Surgical done. Once we've got a trial reduction in, just everything needs to feel the same. The tension needs to feel pretty much the same. You've got to feel that it feels right. In terms of stability, I describe it as the one finger test for dislocation. So if I can dislocate them easily with one finger, I'm not having to use a hook, I'm not forcing them out, but they're not sliding out. So that's a good idea of balance of, I know it's of both. And then look at the soft tissues. Do the tissues go back easily simply with the forceps, not heaving them into about the position you want them to be in? And that's all. It's all a sort of clinical feeling, really. A combination of a number of clinical correlates during the operation. Obviously, there are caveats to that. When you've got a patient who is significantly short for whatever reason before, for a Perthes or something, then you are going to lengthen them, and they are going to feel tight. So you've got to have that clearly in your mind, that you know you're planning to lengthen them by 1 centimetre or 2 centimetres, and that's what you expect to feel. And you need to warn those patients as well, because those patients, then you're going to tell them you're going to try and restore their leg length, and it will be sore and it will feel very weird for the first few months, even if you get it dead right. And that avoids the early complaints on those ones.
So Simon, I'm just going to pick up on one thing that you said there, which was templating. So I want to ask all the faculty about templating. Phil, what are your views about templating? Do you template in everybody?
Yeah, trauma CAD.
Have you always done it? Is it a new thing?
It's a relatively new thing. I'd say probably I've adopted it progressively more and more over the last 3 to 5 years. But now, if the fellow doesn't do it, I do it. But only if there's a calibration ball on the X-ray. If there isn't, I won't do it, and I'll go back to what I did previously, which is the multiple clinical checks, very similar to Simon.
David, your views about templating? You're on mute, David.
No, I think I believe you have to do it. And you must have a calibration ball on the X-ray. Just has to be there. And it's all about expectation. If you expect it to be there, it'll be there.
Okay. And David, I've heard you say this before, and I was hoping you'd just volunteer it then, but I've heard you say that templating is as important, if not more important, than wound closure. Not more important, but as important. Yeah, I mean, you wouldn't think. I mean, if you leave a wound open, it will close by secondary intention, but you wouldn't dream of leaving a wound open. And the same way, I think we shouldn't consider not templating. So Phil, especially if you're using a cementless stem. Obviously, Phil's coming from a different background, and Simon too, cement ed. But if you're using a cementless stem, you really must template. Okay. So you have your hand up?
Yeah, so I'd just like to ask David, really. I mean, I guess the elephant in the room here, David, is how do these patients, the 3 cases we've just shown, how do they get off the operating table long? If let's assume all 3 patients have been templated, and there will be we have to, the templating doesn't get the leg right length, does it? The surgeon does. So your templating has to go hand in hand with how you do the surgery and the checks and balances that you make. Because, I mean, the neck cut argument, I take it 100%, but having a really good idea from translating the template to the intraoperative where you actually put the saw and make the cuts, not that easy. So why are these patients coming off the operating table long?
Well, they shouldn't be. So I think, I think if you're using, I think particularly if you're using a cementless stem,
yeah,
you should never find a tight canal during surgery.
Yeah, 100%.
You should always know about it. And that last one you saw, Phil, or the one you showed, that canal was tight.
Yeah. Okay.
If you go back now and measure that out of interest, it's going to be 10 or less. Yeah. And for me, 10 or less is a tight canal. And that'll cover almost 10% of your patients. So 8% of your patients will have a canal of 10 or less. And I just think it takes a few extra seconds if you're using a cementless stem to remove the canal. And then we use a caliper. I think it's really important to. So I think that the key is your level of neck resection, because you'll never, certainly with a cementless cup, you'll never lengthen the leg through the acetabulum. Leg lengthening is caused by a stem that's too high in the femur. And
David, I also recognise a tight canal in it when I'm planning to use an exeter, actually, and I'm more than happy to get the reamers out for the diaphysis to use a cemented polished tapered stem for the same reason, actually. Yeah,
but it takes a few seconds.
It does.
To measure canal diameter on the X-ray.
Yeah.
The other tip then is people say to me, "Oh, I couldn't be bothered because the calibration's wrong." Measure head diameter on the pre-op X-ray, and then measure it during surgery with a caliper, and therefore you check your calibration. And during surgery, if there's still some articular cartilage left in the head, add on 2 mils. So if you do that, you can check your calibration at the same time. Very simple and quick.
It's fascinating, and we could carry on with this for probably all evening. But for the last 10 minutes, I'd really like to just talk about our last subject, which is periprosthetic fractures. And we've just got 2 cases to show around the femur. So, Simon, can I get you to present this one?
Yeah, thank you. This gentleman came into our unit later on. He's a 59-year-old chap, standard looking arthritis on the right-hand side, nothing special, no other particular history of note. Planned for surgery, had an uncemented hip. Nothing obvious on that initial film, nothing you can obviously see. He was up and about, but rang up 2 weeks to the helpline saying he's got increasing pain and he wasn't happy and not right. Came in and immediately you can see an X-ray and you can see a little crack. So this is just an early periprosthetic. He had no injury, no fall. He'd been using his crutches, doing what he'd been told to do, and it's just subsided significantly and cracked. And when we got in there, the stem was loose. There was a crack going approximately as well, wired round, and a stem put in. Possibly that could have been a little bit longer, but it's probably long enough to bypass in a fresh fracture, which is nicely reduced. But just simply the message of the patient comes back and tells you something has radically changed. Goes home at one day, really happy. A few days later, something's wrong. I've got pain. You need to take it seriously and look for it.
Okay. So, David, you've got a couple of pearls of wisdom about
So
periprosthetic fractures.
So I think accepting extreme trauma, anybody who fractures in the first 6 weeks, it happened during surgery. And obviously it's mostly a cementless issue. And either it's caused by driving a stem into a narrow canal or into a narrow neck. So a narrow canal fracture, Simon has just shown, is actually very rare. But a neck fracture or calcar fracture is very common. So this is an example of a narrow canal in a male patient. Next slide there, just. You can see that it's been templated for a size 12. The canal wasn't measured. And in retrospect, the canal was less than 9, which is very small in a male patient. You can see on the templating there on the hip we're doing, that template is very tight in the canal, but actually it's actually even a bit undersized in the metaphysis. On the next slide then. So it's a bit undersized in metaphysis. Next slide shows that there was a fracture occurred. This is a canal fracture. It's very unusual, as I was saying. So one that Simon showed is not a common problem. But the problem is you don't notice it during surgery. It happens, so it becomes apparent after surgery. Next slide then. And this patient had to have a significant revision procedure done. And obviously, if that patient had had their canal measured and reamed to 10 millimeters, which takes an extra few seconds, it wouldn't have happened. So the simple message is measure beforehand. So commonly in this case is a narrow canal fracture is uncommon. Normally in these femurs now, the approach of the stem will go down. The result is, as we showed earlier, that the stem is just too proud, which gives you an unhappy patient. So their leg is long. So narrow canal fracture is uncommon, but what is very common then is a calcar or a neck fracture. Next slide then. And it's simply caused by a narrow neck, and you can see this when you cut off the head. This patient here is in a narrow neck, and these are the ones that crack. And the next slide then. And a very good paper published on this by Michel Bonnet. And the next one. And the next slide then too. So sorry, if you go back one. So the UK, Australian and German registries. So again, we've 3 big, powerful registries, all showing that if you use a cementless stem with a collar, you totally avoid these early fractures. So the evidence is that using a collar reduces the revision rate in the first year. In fact, it's the first 3 months by 0.8%, and that's across 3 big registries. So the messages are to avoid a narrow canal fracture, just simply measure the canal. If it's less than 10, ream it. And then for cementless stem, I think you should be using a collar, particularly with a narrow neck.
So, David, I've got a question from Pranshu Agarwal. Is it worth exposing the lesser trochanter in every case to recreate the level of your to be able to see your neck properly?
If you're using the lesser trochanter as your landmark, but the interesting thing is that there were comments made by Simon and Phil about a varus neck. Most of the X-rays that we see are in some flexion and external rotation. And that gives you a more valgus appearance. And what that means is that if you use an X-ray, unless it's a perfect AP, which is unusual, you'll tend to make your neck cut too high. So, for example, if you've 20 degrees of external rotation and flexion, which is fairly common. So on the pre-op X-ray, if you see head center at tip of trochanter, then in our experience in Belfast, 499 times out of 500, that's projectional. So on average, head center should be at least 10 mils below tip of trochanter. So if you do that, you'll make an error of about 7 mils. Your neck cut will be 7 mils too high. And that's why I think it's better to use some sort of intraoperative caliper or measurement to measure your height and offset. Now, it's different if you're using a CT scan. If you're using a CT scan, you can get a perfect AP, and then if you're using lesser trochanter, yes, you must expose it, and you measure up from lesser trochanter using a ruler, not your finger. And remember, the male index finger is 22 mils width.
I expose the lesser trochanter in every case. My neck cut is fairly standard because I'm using a cemented stem, so I can adjust my depth of insertion fairly easily. But I'm a bit nervous about making that measurement still, because the point that you choose on the X-ray from where you're going to make your measurement to where you intraoperatively decide where that point was, I'm not sure how easily I really struggled with that when I first started as a consultant. I gave up because I didn't think I could identify intraoperatively what I was seeing on the X-ray, and I had a tendency to make people a bit long actually at the start.
Yeah, so that's why I think a caliper method is better.
Yes.
And you're right. So it's very hard to know where where the mountain of the lesser trochanter meets the flat plane.
Yeah.
Where is that point? You're correct, but I think many surgeons use their index finger, and then you must use a ruler. We shouldn't be using our fingers to measure things.
Yeah.
Okay, that's been absolutely fantastic, gentlemen. So, in summary, I hate to bring the session to a close because I'm sure we could talk all evening. But I think there are some themes that we've brought out from the three topics in terms of dislocation, leg length, and periprosthetic fracture. The keys are to plan, preoperative planning, templating. Obviously, considering the spine is really important. Surgical exposure is absolutely pivotal in all of these, and the use of appropriate implants, whether they be cementless or cemented, is key. So I must thank David, Phil, Simon for an absolutely superb session. I'd love to, it'd be great to do probably a whole session on each of those three topics, but sadly we haven't got time. Obviously, I'll hand over to Vikas now. There'll be more midweek specials every second Wednesday of every month. Vikas, over to you.
Thank you very much, Anil, and echo your sentiments. People have been on holiday, they've had their anniversaries, and they've given up their time to come actually and teach on this webinar. So a big thank you to all of you, and to Anil for an excellent moderation on this webinar. This is exactly what we want, clinical cases discussed in depth by key opinion leaders. We have another 9 of these throughout the year, every month. So please do tune in on the second Wednesday of every month. And most importantly, for those of you who've been able to join us, please do fill in your evaluation forms so that we can keep continuing to improve these series. And on that note, thank you very much and enjoy the evening. Thank you.
Thanks, guys.
Thank you.
Bye.
Thank you. Good night, everybody.
Bye-bye.
Bye.
Hello.